So I'll repeat the question. The personal experience of the questioner is of being an Rh incompatible baby. So that if an Rh positive father begets a child by an Rh negative mother and the baby is Rh positive, there's, especially if they're a second baby, there's a chance of antibodies in the mother attacking the red blood cells of the baby. If that happens severely in utero, you can get what we call hydrops because it just chews up your red cells. If it happens after you're born, it creates a lot of red blood cell lysis, your bilirubin goes high, and you can get what we call kernicterus, which is staining and damage of the brain from the bilirubin.
I was in 6, so...
Right, so you were like...
Kernicterus, everything.
So the question was, she had talked to many people in the rare disease community and found a similar situation. Is there any reason this should be so, and does this comport with our experience? So I can give you a theoretical answer, but I can't give you, I'm not in the rare disease business, and I don't talk to a lot of rare disease people, okay? Rh incompatibility, if you have hydrops can mean fetal loss or premature birth, and that can cause its own problems. Rh isosensitization and kernicterus causes neurological problems. But these should be well recognized. However, they are increasingly rare because we test for this and we give Rogaine.
Rogaine came in at 62.
Right. So, like I said, as you and I with you age, okay, this is becoming less and less common. Now, I don't know that there's any association between Rh negative and Rh positive alleles, spots on the gene, in any rare disease. I suspect that's not so, and even if it were so, it would be with one or two particular rare diseases, not the whole spectrum. So I don't think there's a theoretical reason why your observation should be true.
I don't think it's been studied.
Okay, do we want to take one?
Yeah, we'll alternate. Take a written one.
Thank you.
The first question here is, my child has been diagnosed with Ehlers-Danlos type 3, and then it says 9 out of 9 on the Brighton scale. Cyclic vomiting, POTS, FAP.
That's functional abdominal.
Okay, functional abdominal pain. Gastroparesis, does not have natural bowel movements without Miralax twice daily. Could she possibly have a mitochondrial disorder? I want to say something about diagnoses because a diagnosis is actually thought about as, you know, my child must have a diagnosis somewhere. That's fine, the diagnosis, and it's much more complex than that. First of all, many children do not have a diagnosis. You will never find a diagnosis because there isn't one. A lot of people have, instead of having one particular problem, they have multiple factors. And those factors can coalesce together to contribute towards disease. So I'm talking about some common things like, say, asthma or diabetes. The diagnosis of asthma or diabetes is a description. It's not an underlying biological problem. There is a cause of asthma. There are many, many genes. And there are many, many environmental factors that together cause asthma. Same as diabetes. Same as fatigue or pain or depression or autism. Some of those patients have an underlying diagnosis, a single gene, a single event. But most of them have many genes and many things. So the other thing about diagnosis is that diagnosis comes in different flavors. You could say a child has autism because an autism is the description of the child. It's not an underlying biological issue. And then you can say, well, the child has mitochondrial disease. And that's really a description that there's something wrong with the mitochondria, but that's not an underlying problem. When you get to the exact issue, like Kern-Sayers or Mela's or TRAP or something like that, and that is not perfect either because there probably is more to the child's autism than a single gene abnormality. Or you can say that it's mold or a vaccine or mercury or that it's any sort of environmental component. And that may or may not be related, but it's not the only cause by itself. After all, every child is pretty much exposed to those. Blindness is one form of the disease. So it's part of the problem is that there's a lot of complexities involved in what is the diagnosis. As science advances, we can get closer and closer to the biological relevance as to what the problem is. So back to the question. I mean, things like cyclic vomiting, POTS, functional abdominal pain, gastroparesis, Ehlers-Danlos type problems. Those are all symptoms and signs which are compatible with mitochondrial disease, as well as with other entities as well, channelopathy, neurotransmitter disorders, and some other things I can think of. So mitochondrial disease is something to consider among many other things. I think the thing that we've all been saying here is to keep an open mind. That's probably the most important part of that.
So what I will say is that Ehlers-Danlos type 3 does not have a test. It's a diagnosis by clinical assessment. It is believing we're joint pains from hyperextension, but then there were some issues about the neck and headache problems, which comes into your cyclic vomiting, because cyclic vomiting, many people think, is a migraine equivalent, okay? And then there is just kind of like your chronic body pains and things like that. There's been some work done looking at nociceptors, pain and pain processing in the brain to suggest that maybe these children, or these adults eventually, because they have a normal lifespan, have a predisposition to feeling pain. But they also have a predisposition to being told to worry about every pain, and that can psychologically contribute to their own thing. And that's kind of a worry that you have to balance. Finally, constipation and functional abdominal pain is a everyday in the general pediatric clinic diagnosis. So when your child has a not rare disorder, EDS3, but a defined disorder that's not every day, and maybe your clinician, your general pediatrician has 2 or 3 of those at most, that does not protect your child from having these other problems. And they're not all going to fold into one diagnosis, which I think is kind of consistent with what was said in the earlier part of the answer. It may not all fold together into one thing.
And I have a question for you also, but I think Joel, you've answered, but I just, to finish up on that question about the diagnosis of multifactorial issues, I think that one of the things that a lot of parents I'm working with are discovering is that many diseases probably do have multifactorial inputs, as both of you are describing, but that as personalized medicine, the idea that we can go to the genome and find a cause for many of the conditions we experience is becoming more and more popular, that not only patients and families, but also physicians are more prone to look for one cause to a group of symptoms, and that can also contribute to some of the diagnostic problems rare disease patients face. If your doctor or the doctors who may be having some concerns over your child's care are like, there has to be a gene somewhere, and if your child has these problems, and we've done the exome sequencing, and we've done next generation sequencing, and we're not coming up with something, there are doctors who will actually have increased levels of suspicion that something's going wrong if that genetic proof is not forthcoming. So I think it's a matter of, like Rick said, keeping an open mind, but also talking about these issues with your physician. The idea that, maybe there could be more than one thing going on. There could be multiple factors that contribute to this disease, environmental, genetic, etc. Maybe we won't find a diagnosis. Maybe we will. But just keeping everybody on the team thinking about the fact that it's not always so simple as one gene, one diagnosis, even when we're sequencing the whole genome.
I just want to mention that we're at a transition point right now. Hopefully not too long in the future, maybe even 10 years or so, we'll be at the point that you can run the genome as well as many other tests for looking for environmental components and everything, and get to exact diagnoses in everybody. A few years ago, it was really only based on, except for small exceptions, it was only based upon the description and maybe a few tests that are biochemical or immunological or something. Like we're in a situation now, Ehlers-Danlos was type 3. Some of my patients with that had an exact molecular diagnosis. Most of my patients with that do not yet. Cyclic vomiting syndrome, more than half of them have an exact molecular diagnosis, but almost half of them do not. 5 years ago, almost none of them had a diagnosis. So it's right now, things are transitioning, so it's even going to get more complicated for a while as we go from one type of medicine to a more personalized, more exact type of medicine. And I will say that although a lot of patients do have a single diagnosis, my patients that have undergone fictitious disorder workups, medical child abuse, whatever we want to call it, a lot of those patients now have more than one genetic abnormality that we found, because that increased the complexity to the point nobody could ever find something that accounted for everything, because there were many things that were found, probably many things that we haven't found yet that the child has as well. Some of them are now adults.
So this question is, how do we find a pediatric doctor for primary care? How do we get doctors to communicate with each other? How do we as patients and our parents encourage care teams to communicate or have knowledge of other conditions? And how do we coordinate care between doctors so they are all specialists in certain areas? I think if I was going to sort of summarize the difficulties of raising a child with multiple medical problems, even when it's not a rare disease, it would be these right here. And actually, some of you may not know, but Franciscan Children's Hospital just recently completed a series of surveys through a P4A grant where they actually surveyed parents of children with chronic, multiple, or complex medical conditions, and pretty much these were the concerns that came back right here, along with a few others. But I would say that the challenge of coordinating a team of specialists for a child with many medical problems is almost a full-time job, sometimes for the parents. I often describe it as parents, the parent manages the people who are managing the child's health, and it can be really demoralizing and really frustrating, but as we know, it's really important. So I would say the very first step that I usually advise for parents and families who are trying to get better care coordination is to find the one doctor who seems to be doing a good job. And usually there's at least one doctor on every team who the parents feel like is getting some idea of the overall picture. Go to that doctor. If it's not a primary care doctor, can that doctor recommend a primary care doctor? Who is a pediatrician that, say, your trusted, excellent immunologist knows that does a good job communicating with the immunologist and other specialists? Start there. And then add to the core team. And one of the ways that I usually advise parents to add to their core team is to talk to the doctors who are already on it. Say you have an immunologist and a pediatrician, you need a GI doctor. Who do they recommend? Who can they help you find? How are the ways that you can utilize your care team members to work with you to expand the care, to find people that they like, they trust, you like, you trust, that all respect and communicate with each other?
I agree entirely. I cannot emphasize more what you say about the core team. In situations that have been total disasters among families, and we have turned that around, and it's an amazing success story, it's all because of the core team. And usually it's because of a great pediatrician in the center of the core team. I mean, I'm the subspecialist. There's only so much that I can do. Having me with a great pediatrician and maybe one or two other subspecialists that's GI or neurology or something that I am not, that can really add something. Usually 3 is the perfect number, but it can be 2, it can be 5 in rare cases. But the core team is extremely important. One thing I want to add on that is it is very difficult for physicians to communicate. I don't know why that is. I have some ideas. It's more of a problem on the East Coast than on the West Coast. We're Californians. We're a little bit laid back. We talk to each other. We may argue with each other and disagree, but we do talk more. Here on the East Coast, it's more controversial. People are more at each other. There's more competition. There's more issues. But there's also, you don't get paid for it. The physicians are always saying, I spend 4 hours a day coordinating care, and I can't get reimbursed for that whatsoever. My hospital's telling me not to do it, and send them off somewhere else. Okay?
To piggyback on that, I'm a big proponent of family-centered care, and I guess I'm disturbed to hear earlier you said parents shouldn't speak up, we should let the medical professionals talk about this diagnosis, and then we have care coordination going on, where you've also said the parent is the one often doing that. I guess I want to hear your thoughts on that, because I really think parents should be an equal part of this team.
There's a difference between facilitating and doing. Maybe, I mean, it's that, when you mentioned about, you know, that you talked to, they said, what does the GI specialist do? Go talk to the GI specialist. That's the way it should be in a perfect world, but it's not a perfect world. What a lot of my families do is they say, you know, you should speak to the GI specialist, but here's the GI report. You know, you hand it to you, you know, sort of thing. It says, you know, and that really helps, because if I'm in a room and I spend like an hour and a half off with a patient or something, because I can do that, but it's, you know, instead of me finding the GI specialist on another day, I have a situation I want to talk about right here. I have the GI report. If I have questions, I will, and I very often email that doctor and says, you know, I have a question about this, or what do you think about that? But I have the report, and I know what they have in writing.
If I could just add briefly, the real answer to the question, as originally formed, is simple but crass. It's time and money. That's the problem. It's time and money. Not enough people go into primary care because it doesn't pay well. The average medical student is graduating with $250,000 to $500,000 in debt. It's time and money.
Well, except for the parents, too. We're not getting paid for the GI.
Agreed. All around. There is a grant-funded program in this state to try and do a little bit better care coordination. There's what's called the 4C clinic. We've got one in Springfield, and there's one at Boston Medical Center, I believe, which is an attempt to try and handle this problem. But as soon as the grant funding is gone, unless they can demonstrate a monetary savings to the insurance company, the program will disappear. And I don't know how well it's working.
Well, and I think that part of that is advocating for an insurance code like an ICD-10 code for care coordination would go a very long way toward helping some of these problems, because if it was a billable service, that would increase the physician's ability and propensity to do it. But back to what you said about parents being equal, parents are an equal, and sometimes even a more than equal member of the care team, because they are the ones most devoted to their child, and in most cases the ones who really have their child's best interests at heart. But when we're going to talk about a medical child abuse accusation or potentially developing medical child abuse accusation, the reality is that when you are left to be defending the diagnosis to the doctor, you are not equal in that the doctor who's questioning you, you're not equal in that doctor's eyes, because you're not a medical professional. So it's not that you have an unequal role in the child's care team, but you are not equal to the prescribing or diagnosing physician in defending the diagnosis. And I'm not giving good or bad moral judgments on that. I'm just saying that for the purposes of reducing the possibility of an accusation, that is an appropriate time for the parent to step back and say, let me help you get in contact with the doctor who made the diagnosis. That is more successful in all of my experiences. It is more successful than the parent saying, well, I'm an equal member of this care team, and I'm going to tell you what this diagnosis is and what it means and what the treatment should be. That is rarely successful in derailing an accusation.
You have a question about what was just said?
Just like about what you said, maybe like, so like in summary, like are you saying kind of like, it's not even really about the knowledge, because you were talking about this case earlier, about someone who's not.
Yeah.
It's also an issue of your level of interest in the child and what role you play in the interest of the child, whether or not there's an interest.
I'd like to mention about, when I was in my training, I was always told that the parent, almost always the mother, knows more about the child than anybody else. And to listen to the mother, if you listen to the mother, you'll be right 99% of the time. And I make sure that when I teach medical student and residents and physicians, that they know that that's the way that I feel, and that's what my experience has told me all the time. And there may be a regional difference here, to some degree. And it may just be I'm an idealist. I know there's some doctors on the West Coast who are assholes.
I think there's also insurance differences between the East Coast and the West Coast. And sometimes we skip the whole middle of the country where financials are actually better in medicine and where things may go a little better. So I think there's both cultural and financial differences.
There's also the matter of objectivity. Like Dr. Booth said, an objective finding and an objective conversation holds more weight in dispelling physician concerns than subjective findings. And when it comes down to debating diagnoses and treatment options, the physicians are just simply viewed as more objective than the parents. And so for the purposes of avoiding a very challenging care situation, it is more useful to facilitate physician-to-physician communication.
We take this gentleman over here.
Yes.
Hi.
Oh, yes.
Thank you. I'm a retired firefighter and paramedic. I've had a slew of medical problems over the last 4 years, ranging from allodynia, dystonia, chronic daily migraine headaches, full body complex regional pain syndrome. I go to Philadelphia every 2 to 3 months for ketamine infusions. I've had a slew of doctors over the years. During this time, I've had 2 children, both daughters, 13 and 15. 15-year-old is now starting to show multiple problems from chronic fatigue to shoulder pain, back pain, headaches all the time. We've seen a pediatrician, we've brought her to chiropractors. We're wondering now if she's starting to develop some type of mitochondria or Munchausen's because over the years she's seen me go through so much. Any advice?
I'm going to take your question and slightly turn it to be more generalized because, I mean, none of us can make a diagnosis in this setting. It wouldn't be legal or appropriate, okay? But I'm going to, take it a situation in which there's a lot of aspects of chronic pain that comes and goes over a situation with or without chronic fatigue, with or without a family history. That's why I'm going to change it to that generalized question, not a question in your family. Okay, so it'll be more general for the audience and for the people that will be seeing this on videotape, may or may not apply to yourself. Okay? Now the legalese has been there and the lawyers have settled down. Okay. Okay. First of all, is Dr. Booz, that's who you pronounce it? Yeah. Okay, right. It had mentioned is that there are some people that are more sensitive to pain. I want to take that and bring that into the molecular age, okay? If your toe is hit with a hammer, there's tissue damage. There's receptors that are causing pain signals that are going to the brain, okay? Somebody that has a psychiatric disease may see despair and suffering where there is no pain. The vast majority of chronic pain is not. It's in the wiring between the toe and the brain. Okay, the wiring is hypersensitive, hypervigilant. You can use anything there's many different ways to look at it from metaphorically, but basically actual pain signals are going to the brain where there is nothing in the toe or any other part of the body. So the brain's getting real pain, toe is gone. Okay, so it's not psychiatric whatsoever. It's a wiring issue. Those are often due to abnormalities of sodium channels that have to do with the nerves being fired. They often have to do with many other things from neurotransmission, sometimes mitochondrial, other metabolic problems. We are now to the point that we can make a molecular diagnosis, and I don't know, maybe half the cases in my experience. Many of those have family histories, of course, because this is the gene, but it's not Mendelian. It's not like a disease is going to go from father to child and it's going to be exactly the same. They'll often skip generations and show up in different ways because they are polygenic. They are multifactorial, but I mean, we are at that point right now. The vast majority of the medical establishment doesn't know anything about that. This is all very new. I would suggest going to a major medical facility that has a pain management team that's using molecular diagnostics.
And I only want to correct your language a little bit before you ended the sentence. If your belief is that a child has witnessed you suffering and is now incorporating that and experiencing that same suffering themselves, you would not describe that as Munchausen syndrome or Munchausen syndrome by proxy so long as they genuinely feel the suffering. You also would not describe that as mitochondrial disorder. You don't acquire a mitochondrial disorder from watching someone suffer. Okay? What we're talking about is in the brain spectrum of what we call somatization disorder, perhaps augmented by a prevalence that comes from the fact that she's your daughter and they have one of these transmission issues.
Well, I mean, in my experience, I mean, I've seen a lot of patients and families with somatization. We usually can make a molecular diagnosis, and I mean, not all the time by any means. I mean, it is both the doctor says it's somatization, that there's no real symptom, that the feeling is based not upon reality and what you feel, and to say it's a real molecular diagnosis and there's something biologically right, those are correct at the same time. Because you may feel nausea with a stomach that has nothing wrong with it, or you may feel pain on an inactive foot, that there's nothing wrong with the foot. But there is a real abnormality that can be found at many different levels. Because somewhere in the genes and in the nervous system are not operating correctly. So both are correct at the same time. We can't make a diagnosis in every single situation by no means, but I mean, things have moved dramatically just in the last few years on this.
So I was handed a question which I'm going to hop in next, hopefully quickly. So the first question is about Ehlers-Danlos. Does it cause fractures in children, and what's my belief on that? And then a related question is, I talked about a manufactured controversy, and what do I mean by that? So Ehlers-Danlos is a spectrum of disorders, some which are only phenotypically, meaning we look at the patient, we say, oh, there it is. And some of which have identified genetic and subsequently molecular causes, usually with issues of collagen. Okay? There are multiple subtypes. There are subtypes, I believe it's 6A and 7, both have defined fracture as part of it. Okay? My understanding, not being either a connective tissue expert nor a geneticist, is that they both have type 1 collagen abnormalities, which is the same gene that impacts and creates osteogenesis imperfecta, the known brittle bone disease. When we were talking before, we were talking about Ehlers-Danlos type 3. Now, I was interested to hear your comment about many of them having a defined molecular cause. However, most either don't have a defined molecular cause or haven't been tested for the molecular cause. The diagnosis has been handed out. And as long as things are just kind of routine care, you don't necessarily need the molecular diagnosis if you're receiving satisfying care. But there are a very limited number of physicians who have begun showing up in court and claiming that children have Ehlers-Danlos syndrome premised on fairly limited substance, and claiming that this is a common cause of fracture in early childhood. This is not something that has been demonstrated in research study, and in fact, there was a specific special issue of the Seminars in Medical Genetics which tried to address this and said that as far as we know, this is not true. So for people who then go out and go from court case to court case to court case claiming it's true, that's what I refer to as a manufactured controversy.
This is one of my least favorite situations. When I was at Children's Hospital for 20 years, is being called into a case of a child with suspected child abuse and somebody saying it might be Ehlers-Danlos or osteogenesis imperfecta. Sometimes it clearly was osteogenesis imperfecta or some other brittle bone disease. And in those cases, often the x-ray would show that there is decreased bone. And the fractures were in areas in which kids would normally get fractures, like in the legs and things like that. Other times, there were nothing on the x-ray except for fractures in places that kids would not get fractures if they weren't abused, like in the ribs. Multiple rib fractures is very unlikely, just by falling down or something. But and those cases were difficult, but it's even difficult to make a molecular diagnosis. It's not a good disorder to make. Going forward, there's going to be a lot of problems. Certainly the child abuse ones were difficult to deal with. But there were ones in between that we just could not decide. But usually, it's usually they fit on one side or the other. Usually there are some sort of objective features, like the skin is very stretchy, and there's weird types of scars called like cigarette paper scars, or there are X-ray findings or something else. And now that we have molecular, we can do that as well. We can't find every case. I'm sure there's going to be borderline cases, but the borderline cases are becoming, which used to be most of them, are now fewer.
So here's a question we have is, how should we handle doctors' reports that are inaccurate? And, as Dr. Booth talked about, one of the things that's recommended if physicians are concerned about a potential child abuse situation and they're trying to sort through the different possibilities, one of the things that they were encouraged to do is to gather all the medical records. So they gathered all the medical records and they find that there's a lot of discrepancies. What does that mean? Sometimes it can represent a situation in which abuse might be occurring, and there's been what I talked about, doctor shopping or doctor splitting, where parents are deliberately encouraging different diagnoses and treatment plans and reports from different specialists. Sometimes, I think, as we all know, there can just be inaccuracies. I've looked over medical records in many of the cases in which I've worked, and I've simply noticed that there are just a lot of mistakes. Everything from how old is the kid to what medications they're on to the medical history of when did symptoms start. And these are not signs and symptoms of abuse. They're simply inaccuracies. So how do we handle medical reports that are inaccurate? Go ahead.
I think we're all going to weigh in on this one. I mean, I would first of all divide it if it's factual or opinion in terms of that. If it's a factual inaccuracy, if the dose of the medication is 10 times what it really is, you need to correct that. You don't want someone going to the emergency room and getting 10 times the dose. If it's that the seizure started at 5 years of age and it was 5 months, that could make a difference. That's important. If it was really 4 years of age instead of 5 years of age, probably not going to make it important. If there's a factual thing that you think that needs to be changed because it's a problem, or the doctor said the patient never had this and the patient did have that, and that may be a problem, go to the doctor, talk to the doctor's office to say this is simply factually not true. And you may or may not, in certain situations, have to show something like a doctor's note that says something differently or whatever. You said Dr. X said this, and the gastroenterologist or the neurologist are saying, said Dr. X said Y. Send a note. Say it's not correct. Correct it. On the other, if it's factual, that doctor's office should correct it. If they can't correct it, that doctor's no longer in practice, deceased, or has nothing wants to do with you, and you can't make them do anything with you. Then get another doctor to say, that this has been inaccurately said before, or just, make sure that it's corrected. On the other hand, if it's an opinion, like I do not believe that this patient has such and such disease. And that's important for you when you have another doctor that believes that you really do have such and such disease. Have them say that, and even if possible, say the reason why and why they have a difference of opinion. There are cases in which there's a doctor that's really brilliant and I really trust and I have a lot of respect for, and I don't agree. And I'll state why there's a disagreement. I'll state exactly why there's a disagreement. Doctors say, I don't think this is correct.
So I would say, I would also divide this in two, but I'm going to divide it a different way, which is when you notice what you perceive to be an inaccuracy. If you notice it early, you should absolutely go to the doctor and ask for a correction. But be aware, we can't erase medical notes. You're not allowed to do that. It's illegal. You can draw a single line through a written note indicating that it is inaccurate, but you have to leave it legible. It doesn't get struck from the records, and then you can do an addendum. Okay? In electronic medical records, all you can do is an addendum. Because of what I do, many of my notes are reviewed by people who have strong opinions about them, and occasionally people have come to me and asked for a modification of the note. I always tell them, I cannot remove a statement or a medical note from the chart. I can, however, make an addendum. Now, if you're catching this later in the middle of a child abuse assessment or a Munchausen syndrome by proxy, asking to have old records changed can be problematic appearances. And so I would urge you to be cautious at that time. Merely state that that was inaccurate and just leave it at that.
Here's how I've handled that when parents have come across multiple inaccuracies that they feel are being problematic in a case. What I recommend usually is, again, if you have that core team, go back to them, or if you have at least one trusted physician who knows the child's medical history and has followed for a long time, is that I recommended that parents bring the most inaccurate and most troubling and problematic notes to that doctor, and then they have a discussion about it in the clinic appointment, and the doctor will document that discussion in his or her clinic note and say, Mom and I, or Dad and I, had a discussion about the immunologist note. Mom is very concerned because such and such inaccuracies are in the note, and they appear to be causing a problem in the child's care. I feel that the inaccuracies are not inaccuracies, or I feel the inaccuracies are wrong, and here's why. But what that does is it provides So documented evidence of another doctor and you having this discussion and then doing what Dr. Boles said, giving an opinion on why the controversy exists and what it might